Okay, so welcome everyone to today's session. We have Dr. Rania Habib, and she is a cleft and craniofacial surgeon. So welcome. Oh. Yep, just give us a couple moments before we begin. Great. Hey, Dr. Habib.
Hi.
So, yeah, you can go ahead and begin whenever you're ready.
Okay, let me share my screen. Are we anticipating more people joining or no?
There will be more people joining throughout usually.
Okay. Okay, can you guys see my screen?
Yep.
Hi everybody, my name is Dr. Rania Habib and I'm a clinical instructor at University of Pennsylvania. I am a board certified oral and maxillofacial surgeon and I'm also a pediatric cleft and craniofacial surgery. So the title of my talk today is Oral and Maxillofacial What? Because a lot of people don't actually know what we do. So we'll get started. Let me share full screen here. So I have nothing to disclose. I have no conflicts of interest and I'm not endorsing any products or services today. So I want to talk first a little bit about my pathway. So I was born in Denton, Texas, which is just north of Dallas, and these are my three siblings, and we are diehard Cowboys fans. So a lot of people give me a lot of slack for that, but I was actually born and raised in Texas, so that's the reason for that. My family's originally from Egypt in this little town up here called Tanta, and this is me in front of the pyramids. We try to go every 2 to 3 years, but obviously with COVID, that's really thrown a wrench in things. I then went to undergrad and dental school at University of Minnesota, and this is Moose Tower, which is my dental school at University of Minnesota, so it overlooks the Mississippi, and it is the tallest dental school in the world. It's actually 19 floors, which is really cool. So I did my undergrad in microbiology and then my DDS, which was 4 years. Then I went on to train and do my 6-year joint MD program at University of Maryland. And this is a picture of the University of Maryland Medical Center. And this is one of the oldest medical buildings in the corner here in the country. And this was all decked out for when the Ravens won the Super Bowl, which was really fun. I then did private practice for 2 years, realized it really wasn't for me. So I went to fellowship, and this is a picture of my fellowship. You can see me here. We were doing Movember. This is my fellowship director, Dr. Barry Steinberg. And that is when I did a full scope cleft and craniofacial fellowship. I then went on to LSU, and I was the first female oral and maxillofacial surgeon attending there. And I was there for about a year and just realized I didn't enjoy life in the South too much. So then I was recruited back to Philly. And now I'm just a Cowboys girl stuck in my Philly world. So that's kind of my full circle story. So I've been all over the place. So my path to dentistry was a little bit different than most people. So I actually started out as American Heart Association scholar at the University of Minnesota. So I worked in a research lab there where we did last stop FDA approval on heart devices. So it was called Experimental Surgical Services, and it was a really great opportunity where we the last stop was basically animal research before we went to the studies in humans, and I majored in microbiology. then did my senior honors project on developing an assay to detect sepsis using TNF-alpha, and it failed miserably. So I can tell you firsthand that even though you may fail at something, you can pick yourself right back up. This was my senior honors thesis. It was really tough not having that to present. And then I was shadowing my cardiothoracic surgery fellows and the general surgery residents were pretty unhappy. And so I was like, well, what's going on? And they kept telling me, like, have you thought about something else? So I did, I started shadowing the full realm of medicine in all fields, including my general dentist. And I realized that dentistry was a really cool field. So why did I choose dentistry? So it blends engineering, artistry, and oral health, which I thought was really cool. So we always joke that doctor, engineer, plus artist gives you dentist, which is really neat. So there's a unique surgery on all the teeth, which is really interesting. And then there's long-term patient care and rapport, which is really important. So there's a variety of specialties. And there's actually 10 specialties within the dental field. That includes dental anesthesia, dental public health, endodontics, oral pathology, oral radiology. My favorite, obviously, oral and maxillofacial surgery, orthodontics, periodontics, prosthodontics, and pediatric dentistry. So there's a lot of really cool specialties. It's a wonderful lifestyle. So you can be a job owner, you can work in a hospital, you can work in a clinic, or you can even work at a dental school, or you can own your own private practice. You can work in a private practice. So it gives you really a very broad scope of places that you can work. Dentists are very happy and love their career. I would say compared to a lot of my friends who are physicians, there's like 95% satisfaction rate in dentistry. Of course, that varies based on fields and things like that, but they truly do seem to love their career. So when I asked a lot of the dentists that I shadowed, about 90% of them said they would never opt for another career, which I thought was really interesting. So what exactly is an oral and maxillofacial surgeon? So I could never shake my love of surgery, right? So I was like, well, how am I going to blend dentistry and my love of surgery? And my counselor said, well, what about oral and maxillofacial surgery? And we nicknamed that OMFS. So I found myself in dental school really drawn to the medical management of my patients. Like, why is your diabetes under control? Why is your hypertension not under control? So I fell in love with the complexity of operating on the head and neck. It was a perfect blend between dentistry and medicine, and there was a variety of subspecialties, and they're kind of all listed here on, this is the front page of the American Association of Oral and Maxillofacial Surgeons. So wisdom tooth management, dental implant surgery, extractions and other surgeries that we do, head and neck pathology, corrective jaw surgery, facial injury and trauma surgery, TMJ and facial pain, obstructive sleep apnea, facial cosmetic surgery, cleft lip and palate and craniofacial surgery. And then we also administer anesthesia, which makes us very unique. So also it gives you a flexible surgeon lifestyle. So what exactly is oral and maxillofacial surgery? So we are experts in the face, mouth, and jaw, and that's our statement from the American Academy of Oral and Maxillofacial Surgeons. It's an advanced degree post-dental school, and it's a 4 to 6 year residency program. The 6-year program features a fast-track medical degree, and it's 1 full year of general surgery. We are required to take all USMLE, including steps 1, 2, and 3. We do residency training, including OMFS, general surgery, and anesthesia training, and that's about 5 months of full anesthesia training. So we're literally in the operating room with the anesthesiologist, and we basically act as their residents. For board certification, it's through the American Board of Oral and Maxillofacial Surgery, and it's a 2-year process once you graduate, and then you're a board certified oral maxillofacial surgeon. So the scope of practice includes facial cosmetic surgery, oral, head and neck, and benign and malignant pathology, oral, head and neck microvascular reconstruction, facial trauma, orthognathic surgery, which is jaw surgery, pediatric and adult cleft and craniofacial surgery, oral surgery, which includes implants, dental alveolar surgery, and extraction, so anything really in the mouth. And then for anesthesia, we can administer conscious, moderate, deep, and general anesthesia, which is really a unique factor. So what was my specific pathway to OMFS? So, or how do you get into OMFS? You can do any undergraduate degree, any major that you want, and you complete pre-dental requirements. So in the US, it is still a dental subspecialty. Then you need to sit for the dental admissions test. This is while you're in undergrad. It's the equivalent of the MCAT, but for dentistry, we nickname it the DAT. And then you go to dental school. And what's unique in the US is there's 2 different degrees, just like MD and DO. We have DMD and DDS, and that stands for Doctor of Dental Surgery, which is DMD, or Doctor of Dental Surgery, which is DDS, and then Doctor of Dental Medicine, which is DMD. So you do a comprehensive basic science exam. So it's called the CBSE, and that is the entrance exam that you take in your third year of dental school. And the goal is to score at least a 70 or higher, and those numbers are rising a little bit, but that gives you kind of our scope to see, can you pass the USMLE and things like that. So that's kind of your entrance exam you take while you're in dental school. Then you do oral and maxillofacial surgery residency. You can either do a 4-year certificate program, or you can do a 6-year joint MD program, which combines your OMFS certificate with your medical degree, which is really cool. Then you do your board examination, which is the American Board of Oral and Maxillofacial Surgeons, which we nickname ABOMS. And then you can do fellowship if you choose to subspecialize in any of the interesting fields, and that can be 1 to 2 years. So the roadmap to success is that you want to start off with shadowing in oral and maxillofacial surgery. You want to meet with faculty to announce your interest while you're in dental school. You want to bring, once you set up that meeting to meet with them, you want to bring your updated CV. You want to obviously dress up, because this is a professional manner. You really want them to take you seriously. And I always recommend asking for formal mentorship. So I really like the way that you operate. I love the way that you teach. I would love for you to be my mentor. And those surgeons are likely going to have different criteria for mentorship. Think about doing some research, and then join OMFS interest groups that might be involved at your school. It's really important to attend OMFS ground rounds and any special events that the department puts on that they allow students to attend, because you really get to mingle with other surgeons, the other residents, and really get your name out there. Consider shadowing in the operating room. Meet regularly with your mentors to make sure that you're on track for residency. Extern at different distinct residency programs, or externships are like mini rotations that you can do at outside programs. With COVID, it's a little bit more difficult. Some of them are virtual, but it's a really great way to get your name out there. And then lastly, you want to maintain excellent grades, your class rank, and score well on all your national board exams and the entrance exam, which is the CBSE. And then consider volunteer work, because it looks really good, obviously, to give back to the community, and that makes you a really well-rounded candidate. Plus, it feels really good to give back. And then I always tell people, even though you want to do oral maxillofacial surgery, you need to learn dentistry and all the specialties, because that's really going to make you succeed in the field. So what are some tips for a successful interview? Because I know that interviews are coming up soon for both dental school, medical school, residency, and they're all kind of the same. So research your programs that you're interested in applying ahead of time, and so that makes you a little bit more competitive, because you already know what they stand for. Dress professionally, we know that's really important. You want to ask questions, so come prepared with some really detailed questions. You might want to say, well, I noticed that you don't have head and neck oncology at your program. Do you have any ways to expose your residents to the head and neck pathology? Because I'm really interested in that. Something like that, where it shows a deeper level. Practice delivery of your answers and questions ahead of time with someone that you trust. Try to remove fillers from your speech. It's not, you don't want your doctor sitting there going, oh my gosh, it's just not very professional, right? And you're not going to have a lot of faith in that person. So you want to polish your speech, remove fillers, and be able to deliver your thought process in a very clear and concise manner. You want to make eye contact. So if it's virtual, training yourself to look at the camera, not the screen, so you're not looking all over the place, right? It's really distracting if I'm talking to you guys and staring at the ceiling, right? Or staring down at the floor. So practice looking at your camera as if you're making eye contact with that person. Smile, because obviously we have shown in multiple studies that it makes you more appealing, and it makes you more friendly, and people really want to choose people that they can work harmoniously with, because it's a team effort. Pay attention to your gut instinct while you're at that program. There's going to just be something that clicks about certain programs that you're like, I want to train here. So make notes of that. And then make a spreadsheet of pros and cons that are important to you, because they're all going to start to blend. So I had a really nice Excel spreadsheet where I wrote down all the programs, and I put pluses and minuses and things that stood out, and then I used that to make my rank list. And then I always recommend only interviewing at programs that you would attend. If you know 100% you don't want to go to a program, why apply there? Because you could end up there. So I don't think that's a good idea. So how do you stay sane in residency? So these are kind of things that I did to keep my life sane while I was there. So one is being a sponge and soaking it all in. Residency is going to test you in so many different ways. So it's really important for you to soak in everyone's different methods and really think about how to do it. Find your tribe. Your tribe are, these are my girls that I'm very close with. They kept me sane, right? And that includes your family and your best friends, but that really helps you when you're stressed out. You can rely on them to help you get through that stress. You want to schedule time for you every single day that has nothing to do with residency, even if it's only 5 minutes and you want to just go outside, get some vitamin D, get some sun, some fresh air, it's going to make a world of difference. Put your phone down, you know, stare at the ceiling, watch TV, have your best meal, whatever, but you got to take some me time every day so that you're nice and relaxed and calm. Exercise. I always tell people it's not just for your fitness. We've shown that it increases endorphins, it decreases stress, obviously includes life, it increases your longevity of life, it decreases all these diseases. So even if you're just going for a walk, that is exercise, you're gonna feel better, get up and move. Eat healthy. So I was a big meal prepper and I still am to this day. It really keeps my life sane. So it helps me cook a lot of really fast meals and then have meals throughout the week. Drink tons of water. And this is tough for my surgery residents because I am guilty of this too. You don't want to have to go to the bathroom when you're in the operating room. So you do have to tweak that a little bit, but outside of the operating room, drink a lot of water so that you can stay hydrated and your kidneys don't take a hit. Take your vacation. So this was one of my favorite vacations I took after fellowship before starting my job. I went to Australia for 3 weeks and I finally dove the Great Barrier Reef. I'm a mastery level scuba diver and those little things kept me sane. So take your vacations. You need to relax, and we've shown in studies that when you get back from a vacation, you're actually more productive. Go outside, get vitamin D, fresh air, makes you feel better. So what are some of the job options in OMFS? It's actually very, very vast. You can do academic medicine, you can teach at a residency program or a dental or even a medical school, and that's what makes this really unique is you can actually be in any of these things. You can work at a hospital, which is a non-residency program. So a hospital that says, hey, we want you to come on board and be our oral surgeon. And you'll basically do all their cases, whether it's trauma, cosmetics, etc. Private practice, you can think about being an owner versus working for someone and being an associate. You can be part of a corporate group practice, an independent contractor for other dental specialists where you actually go to their different offices and contract. And then you can be a hybrid of any of the above. So why did I specifically choose a career in academic medicine? So I love the operating room. It's one of my favorite things to do. I love to teach OMFS residents and then dental and medical students. My dad was a professor of accounting, and I think he really instilled in me that importance of teaching the next generation. It feels good, and it's really one of my favorite things. You're making a difference. It keeps me up to date on the latest advances. So in order for me to teach, I have to constantly read the latest literature and learn the latest techniques and make sure that I know what's going on. And then I love public speaking, and that's to advocate for my field, my patients, and really help people understand what I do. I love practicing my subspecialty of cleft and craniofacial surgery, and that's tough to do outside of an academic institution. And I love collaboration, which includes a lot of multidisciplinary care. So before we start cleft and craniofacial surgery, I'll take a quick pause and see if there's any questions that I can answer. Do we have any so far?
Yeah, so I posted the questions in the chat box.
Okay, let's take a couple of these right now. Have you experienced any cons in your career pursuing craniofacial surgery? Yeah, so craniofacial surgery is a tough field because, as you will see when we go through, there are 3 different surgical subspecialties. So we can work, you can be a cleft and craniofacial surgeon from oral and maxillofacial surgery, from ENT and plastic surgery. So the numbers in the US are pretty low. It's good for the kids that it's not very prevalent, but for surgeons like us who really love this type of surgery, we have to split those cases amongst a lot of people who want to give back to the community. So that just makes it very competitive, and it does make it hard to break into the realm of cleft and craniofacial surgery. What was the most complex and difficult situation you had while dealing with a cleft patient? So I think for me, it's always that you can perform the most amazing surgery and your repair is perfect and you're super happy, but you cannot control how the patient scars. And that is what's really tough. So there's a lot of things that go into cleft and craniofacial care. The parents have to clean the wound. They have to keep all of the debris out. They have to do some massage so the scar doesn't contract. And we don't know how that patient's going to heal. It can be variances in nutritional status, or maybe, you know, they pull on their lip a lot, or they're traumatizing the area. So that can create scar, and it can actually then heal not like you left the operating room table. And I think that's the hardest part for a cleft surgeon is, you know, everyone's leaving the OR being like, oh my gosh, we just did the most amazing surgery. And then the patient comes back and, you know, it's covered in scars and they weren't cleaning it. And then you open all of that up and then the whole thing's open and you're like, oh my God. So those moments are just dreaded, and it's super tough to actually deal with that. What influenced me to do this type of surgery? So I think I answered that pretty much in the beginning. So it was could never shake my love of surgery. I wanted to be a surgeon from a really young age. And so when I switched into dentistry, it was a great field, but it wasn't quite the right fit for me. So I debated going back to medical school and going through formal training to go back into surgery. And then I discovered OMFS, and I'm like, oh my gosh, this blends both worlds. I can still go back to medical school. So that was a really unique pathway for me, and it fit my interests really well. How long did it take to become a cleft and craniofacial surgeon? So like I said, it was 4 years of undergrad, 4 years of dental school, 6 years of my OMFS residency with medical degree, and then a 1-year cleft and craniofacial fellowship. So 15 total years post high school, which is a lot. What is it like? Let's see, where was the other one? What is it like to work in your field of medicine? So our typical day is basically, we show up at work and we will round on any patients that are on our service at that moment. So it could be your patients in-house, or if you're on call, you have to go and see those for the morning. Then usually the residents will huddle and they will go over what to do for the day. And then we all go to our various clinics. So on clinic day, we will usually do outpatient procedures in the clinic from 8 until noon or 8 until 1, depending on how your clinic is set up, take a quick lunch, and then usually see consults and follow-ups in the afternoon. And those outpatient surgeries are generally like minor oral and maxillofacial procedures, like maybe extractions, implants, biopsies, simple things that don't require the operating room. And then we can do that either under local anesthesia, nitrous oxide, or with one of the levels of sedation, and we can provide that in the office safely. We always have people who are ACLS and PAL certified, so it's extremely safe. And then generally once that's done, if we have any operating rooms, and your operating room, you know, depending on how busy you are as a surgeon, you might only have certain operating room days. So it might be 1 morning a week, a full day a week, 2 to 3 days a week, and that builds up as you become more senior. And then typically in the evening, again, you're rounding on any patients that you need to see that are either on your service or came in on call. We do take facial trauma call, and that's split differently at every single hospital. So generally, like at Penn, we rotate with ENT and plastics. So we vary that call based on which hospital we're covering. Okay, let's see. So I asked the typical day and why I chose a specialty. How long do surgeries last, and how often does a surgery involve someone from another specialty like neurosurgery, plastic surgery, et cetera? So surgeries can be as short as 10, 15 minutes if you're just doing something simple like an incisional biopsy. They can be long as 13 to 14 hours if we're doing a microvascular reconstruction on a major, let's say, oral pathology or oral cancer. Cleft and craniofacial surgeries for me, I would say cleft lip, palate, and distraction osteogenesis for me is about anywhere from 1.5 hours to 2 hours, depending on the difficulty of the case, sometimes a little bit more. Orthodontic surgeries, which are the jaw surgeries, for me range anywhere from 2 hours as high as 4 to 6 hours. And then for me, probably one of the longest surgeries I do is an open craniosynostosis repair. So a kid whose skull bones fused and we're opening them up. And those are cases that we will do with neurosurgery. And then we do a lot of joint cases with ENT and plastics, depending on what we're doing. But as a cleft and craniofacial surgery, I can do full scope cleft and craniofacial surgery on my own. But let's say the kid has disease of the ears, then ENT might pop in. Someone who's not cleft and craniofacial trained, but pediatric trained in ENT might come in and do their ear surgery at the same time. So we try to combine those surgeries as often as we can to minimize the child's exposure to anesthesia. What is the most common type of surgery that I perform? So the most common type in the clinic are 3, dental implants, complex extractions. So these are teeth that are impacted in weird positions, and biopsies of oral pathology. For me, it's mostly benign, but I will biopsy some malignant lesions. And then since I'm not a head and neck oncologist, I'll send it to my colleagues. Most common type of surgeries I perform in the operating room would be cleft lip, cleft palate, distraction osteogenesis, craniosynostosis, orthodontic surgery, which is jaw surgery where we break the jaws and move them in a correct fashion, and then facial trauma and benign pathology for me since I don't do malignant. Okay, so I'm going to keep going a little bit and then we'll take another break and ask some more questions or answer some more questions. So what exactly is cleft and craniofacial surgery? So cleft and craniofacial surgery is basically complex reconstruction of the head and neck, and they're generally congenital or acquired anomalies. So they can be kids that are born with different syndromes or different anomalies of the face, and that we reconstruct, or it could be acquired. So maybe they had trauma or something happened later in life, and then we can reconstruct those defects. So why I love cleft care is because it's multidisciplinary care. So it's regulated by the American Cleft Palate Craniofacial Association, as known as the ACPA, and they define 6 major components essentially to the quality of care. So the team composition, team management and responsibilities, patient and family and caregiver communication, because we want to make sure that the family is always on board and they know what the child needs. Cultural competence, because it's really important for us to define based on culture, you know, what is going on with the child. So you have to remember that in certain cultures, they might think that a cleft is, you know, the work of the devil or something like that, rather than a genetic disorder. So we really try to communicate, understand those differences in culture, and then use education to help them understand that, hey, like, it is nothing that you did wrong. This is just, you know, a genetic malformation. We try to also make sure that there's a lot of psychological and social services, because we want to not only support their healthcare needs, but also support all of the mental health needs that go around these complex defects. And then outcomes assessment is really important. We don't want to work in a bubble. We want to make sure that our outcomes are up to par with everyone else's outcomes across the country. So it's really important for us to go back and really critically look at our outcomes and make sure we're being held to the highest standard. So this is the typical makeup of a cleft and craniofacial team. So the surgeons can be 3 different surgeons: maxillofacial like me, plastic surgery and ENT. The dental component is actually very important. So usually you have a pedodontist, which is a pediatric dentist, or a general dentist for the older kids once they kind of age out of the pediatric dentist. The orthodontist, who plays a really key role in aligning any misalignments of the teeth. The prosthodontist, that's someone who might help create little devices if there's like little defects in the mouth that need to be covered, or maybe the child has less teeth and they have to figure out ways to either make like little bridges or little mini dentures or things like that. Dental hygienist, because oftentimes if there are any cognitive slowness or anything, or cognitive, what's the right word, delay, we want to make sure that, and they can't brush or the family can't brush, we want to be able to give them a hand to make sure we can keep the teeth as long as we can. From the medical standpoint, we have pediatricians, audiologists, speech therapists, and social workers. So these first 3 categories, you have to have a member of each of these in order to be considered a cleft and craniofacial team. The auxiliary team members include neurosurgery, genetics, ophthalmology, radiology, and a psychologist. And obviously we really rely on those psychologists because a lot of these kids will have a lot of concerns and teasing in the school. We want to make sure that their mental health is taken care of just as much as their systemic health. So team management and responsibilities, we want to anticipate and guide care throughout the life of the child. The child is seen on a yearly basis during key surgical phases, and then we can use those, when the growth phase of care is complete, we can spread out those gaps as often as we need. Team serves as an advisory board to coordinate treatment with regular providers, so their pediatrician, their pediatric dentist, and specialists. So we don't necessarily make them see all the specialists on that team, but we all meet together, we put our heads together because we're all cleft and craniofacial trained, and then we can reach out to their providers and say, hey, this is the next step that they need. They always have the option to use our services, but we don't push that on them because we know that people might be driving from far away and it's difficult to coordinate care. So these are a few of my favorite surgeries. So I will just remind everyone that these are my original images. They were given written permission from the parents. All of the pictures are blacked out so you can't identify the child and see the eyes. But please do not reproduce any of these images without my written consent, because it's actually a violation of the policy if you haven't received written consent, which is only my consent. So I'm really happy to share these with you, but they need to stay private. So this is an example of a unilateral complete cleft lip and palate. So this was on the right-hand side, and you can see this is the before photo where that cleft goes all the way through the rim of the nose and through the nasal sill, through the entire lip and through the palate. Now these pictures were sent to us by the family because this was a mission trip that we did. So I apologize for the blood, but you can see that the Cupid's bow is really well reconstructed. You can see that the nasal rims are now fully equal, and you can see this nice curvature to the nose. So we are restoring form and function. So this kid will really be able to eat now without any difficulty because that cleft in the lip has been repaired. This is another example of a really wide cleft. It's so wide that you can see that the breathing tube is just sitting right through there. But again, another right side complete cleft lip and palate, which is actually really rare because the left side is more common. So this you can see is my final reconstruction. So you can see that the Cupid's bow is even on both sides. We've reapproximated the nose so that it's nice and symmetric. And we've made sure that the wet and dry part of the lip is all reapproximated well. So this is my favorite cleft palate repair, which is called the Bardak palatoplasty with intravelar veloplasty. And it's very confusing, but basically we create two flaps on either side of the cleft based off of the blood supply from the greater palatine artery. And then we make sure that we expose those flaps, their full thickness. So on this picture, you see that we're all the way down to bone. And then we advance each side of those flaps and we close in 3 separate layers. So we close first the nasal layer. That's to make sure that the nasal cavity is isolated from the oral cavity. Then we do the musculature of the levator veli palatini and the tensor veli palatini, which are the muscles that tense your palate and make you say ah, so they make your palate elevate. And then the third and final layer is actually the oral mucosa. So think about the skin on the palate. That's the last part that we do. So what does that look like intraoperatively? So this is a pretty wide cleft. It's a complete cleft of the palate. And so here in the picture, you're staring up into the nasal cavity here, and you can see that the uvula is split, otherwise known as a bifid uvula. So we repair the nasal mucosa. So you can see up here, the nasal mucosa is closed. It's closed back here. Then the next step is to put the muscles. So the muscles are abnormally oriented front to back. And so we cut them and we rotate them horizontally to reconstruct the sphincter. So these are now horizontal in fashion, and we really tighten them to make sure that they move. Then we advance both these flaps, and this is the final picture where we've closed that entire cleft palate. So you can see that the uvula is no longer bifid, and it's really long. We've reconstructed both of these pillars, and so now that uvula can touch the back of the throat and the kid can actually speak. So restoring function so that they can swallow well and they can phonate and restore all of the functions of the actual palate. And then the next step in cleft care is the alveolar cleft. And so this is a depiction of how we do it. So an alveolar cleft means that there's a gap in the upper jaw, the maxilla, and that includes the bone and the soft tissue. So we make this H or a T flap, you can call it whichever one you want, along the cleft. And then again, we're closing it in 3 layers. So we're making a split thickness cut so that we can close the palate and the nasal mucosa. And then we stuff it full of bone, and there's all different ways that we can get bone. We can get it from the hip, or we can get it from a jar. And then the final layer is to close the mucosa. So when you look at this as a 3-layer closure, so the nasal mucosa up here on the superior part, the palate, which is back here, we put the bone in there, and then we close the mucosa over the top. So that's how we get that 3-layer closure. So this is what it looks like in the mouth. So this is the patient's upside down on the table. So this is the upper jaw here, and then you can see they've got all the braces on. These are the 2 central incisors, the lateral is missing, and then this is the canine. So you can see that this is the gap here, and we've repaired the nasal mucosa, which is right here, and that's what my instrument is holding down. This is bone from the hip that we've now stuffed into this area, and we like the hip bone. It's kind of the gold standard because it has a lot of progenitor factors like BMP to help that bone solidify. And then the final product is that the palate's completely closed, and then we advanced that mucosa over the top, and we've closed this entire defect. So distraction osteogenesis is another common procedure that we do in cleft and craniofacial surgery. So the concept is that we want to generate bone based on a tension stress theory. We want to do gradual lengthening of the fracture of the osteotomy, and that promotes bony formation across the gap. So the biological basis is that as we are pulling on, we create that cut in the bone, and as we gently pull at a rate and rhythm every day, we're going to get bone to regenerate in the middle. So it's called de novo membranous bone growth. And it decreases relapse because we're stretching the soft tissue at the same time that we're creating bone. So we don't have that soft tissue acting as a rubber band and pulling that tissue back. So what are the phases of distraction osteogenesis? So again, the theory is that traction across the osteotomy, which is a fancy word for the bone cut, proliferates the soft callus while delaying complete calcification across the fracture. So that means we're going to get gradual deposition of bone. Then once we hit the actual length that we want, we stop and we let it solidify. We always overgrow the bone about 20 to 30% because we know that as the bone solidifies, it's going to shrink a little bit. So we want to account for that relapse. So the first phase is called latency, and that's from the time of the osteotomy, the cut in the operating room, until we actually start turning the distraction device. Activation is that period where we're putting traction by the 2 foot plates on either side of the fracture, and we're pulling gently, 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 so we get bone placed in the middle. And then the third phase is holding that construct out, the gap out, and letting that bone now solidify. So we have to make sure that that's an adequate time for the bone to solidify. So what's the utility of distraction? The goals are to improve airway, feeding. We can do it for occlusion, the facial profile, and we can even use it for cranial vault reconstruction. It relieves the skeletal discrepancy while preserving the soft tissue envelope. It eliminates the need for a bone graft because we're gradually growing bone, and it decreases the operating room time. We also decrease donor site morbidity because we're not borrowing bone from another part of the body. And it decreases relapse because, like I said, we are stretching the soft tissue while we're creating bone, so we don't have that soft tissue pulling back to create more scar and causing the bone to shrink even further. So let's look at the surgical technique and how we do that. So I'm going to use the mandible as the example, which is the lower jaw, because it's the easiest one to understand. So this picture is from the Atlas of Oral Maxillofacial Surgeons. I want to give them full credit, and it's a wonderful illustration. So basically, we intubate the child and we put their head on a gel horseshoe headrest. We put a shoulder roll so that we can elevate their chin up to the sky so we're not hitting their neck or their body as we're doing our surgery. And then the concept is that we're going to do a tiny little submandibular incision a few finger breadths below the neck so that we can miss the facial nerve. We expose the bone, we find the mandible, and then we do this C-shaped osteotomy. The reason why we do C-shape is because there's little tooth buds still forming in this jaw, right, all the way through. We want to make sure that we're missing the last tooth bud by putting it behind that last tooth bud. Then we're going to apply these foot plates. So this is the actual distraction device. So 1 foot plate goes on either side of the fracture. Then the device will come out. I like to come behind the ear because it creates less scar, but you can also have it come out the front. And then we turn this activation arm, and that's what slowly moves the bone. So what does that look like in real life? This is what we outline the mandible in the OR. So we're going to create this line that outlines the mandible, and then we're going to do where we're going to actually make the cut. So we make that little cut, and through that tiny, tiny little cut, we expose the mandible. So this is the lower jaw, and this is that C-shaped fracture line called the osteotomy. And then we apply the fracture device across that osteotomy, 1 foot plate on either side, and then the arm is coming out through a tiny hole in the back behind the ear. And then as we turn the device, now we're going to see growth. So this was one of my later cases, and you can see how tiny the mandible is. You can't even see this child's chin. And at the end of distraction was about 19 millimeters that we moved the jaw forward. You can see it's really prominent. And we purposely put that jaw really in front of the upper jaw. So it's called class 3 dental malocclusion, because we know that it's going to relapse about 20 to 30%. And we also know that if the kid like this one has Pierrot-Benz sequence, that lower jaw can't grow the normal way that the upper jaw grows. So this is a sequence of another child who is, this is the before picture, this is the after, and this is what they look like post-surgery. So smiling well, no facial nerve injury. This is a stickler kid, so you can see that the nasal bridge is super flat, and then very minimal scarring here on the outside of the chin because my incisions are so tiny. So really significant difference. And this child went on to feed and eat and everything healthy and grow really well. So it's a very life-changing formation. And then finally, let's talk about craniosynostosis. So craniosynostosis basically means premature fusion of sutures. And so the sutures are the ones all outlined here. And the function of those sutures is that it's going to allow for head deformation during when the child is birthed, and then head expansion as the brain grows. So think of it as like those sutures are like a blooming onion, and it allows the brain to grow. So these are the anterior fontanelle, the posterior fontanelle, and then all of the different sutures. So this is the metopic suture. The coronal suture comes across, think about it like a crown. The one that goes from front to back, from the anterior to the posterior fontanelle, so from here to here, is called the sagittal suture. And then in the back, you have a double arm that comes down, and that's called the lambdoid suture. On either side over here, across the parietal bone, you have the squamous sutures, and those are the major ones. There's also some minor ones. So the functional consequence of craniosynostosis is that you can have intracranial hypertension, which means high blood pressure of the brain. You can have visual impairment. So think about if your brain can't grow. So any of these common patterns here where it's fused. So this is sagittal. This one is the coronal suture, and you can have any combination of these. You can see that it's restricting growth of the brain or the cranial vault in such a way that you're going to get a different shape of the brain. So that is what the pressure can build up and cause intracranial hypertension. The visual impairment again comes from that high blood pressure of the brain. You can have limitation of brain growth because if the skull can't expand, that brain is going to get squished essentially in the brain, and it can't grow into the way that it needs to. You get neuropsychiatric disorders, and they're not 100% why. They think it might be from limited brain growth. There's still a lot of studies being done on this. So what does the surgery look like? So we can see here, this child actually had synostosis of the metopic suture here, and that's why there's triangle shape here. And she already had surgery once, so we're going through the exact same line. So on the operating room table, we expose her old suture, and this is how we mark it. And then once everything is exposed, so this is the whole skull exposed, we actually put this really cool device on there that helps, that we've already pre-planned the surgery. It's called virtual surgical planning, and we mark out all the cuts that we're going to make on the skull. And then in this procedure, you can see we have exposed the whole skull. We took this helmet off, and now we're going to cut along these lines. We label them with letters so we know exactly where every piece goes. We put those pieces into this plating guide here, then that allows us to then replace it on the skull in the correct fashion with all these gaps. So we've recreated the normal head shape, and we've expanded that bone so that the brain can grow adequately. And then because the child is still growing, we use resorbable plates and screws so that they will dissolve in about a year. And then this is the final result. So that triangle forehead that we had from her front suture being closed, now she's got a really nice round head that has normal shape. And then it's a very, very minimal incision. So they had a really great outcome. And this is a surgery that we do with neurosurgery. So neurosurgery helps us make all the cuts. We do all the reconstruction, and it's a really beautiful, harmonious surgery where we work together as a team. So it's one of my favorite surgeries to perform. All right, and finally, let's talk a little bit about women in OMFS. For those of you who follow me on Instagram and TikTok and social media, I'm a big advocate for women in OMFS. And the reason being is because we only make up 8% of practicing oral and maxillofacial surgeons in the US, yet women in dental schools make up over 50%. So why? Why are there not more women going into OMFS? So this is the first woman who was accepted into dental school. Her name is Lucy Hobbs Taylor. She was at the Ohio College of Dental Surgery, and she got her dental degree back in 1866, which is really important. Unfortunately, the first oral and maxillofacial surgeon wasn't until 1960, and her name was Elaine Stubner. She went to the University of Illinois in the College of Dentistry, and she was at the Cook County residency. So how are we successful as women in a male-dominated world? So I always remind any surgeon who's interested in doing, just be true to yourself, be true to who you are, be part of the chain in combating sexism. So think about ways that you can call out sexism that you hear. So, hey, nobody likes hearing that. I'm not sure what you're talking about. Could you repeat yourself? So trying to help that person without being super confrontational, see what they've said wrong or done wrong and get them to think about it. You can say, you know, that's pretty offensive if you think about what you're saying. And you can say, is it just me, or does everyone here think that was a little bit out of line? So they kind of get a little bit more aggressive, but this group called Our Watch really has some really great ways of how to combat that. And then, you know, we can even say something like, would you say that to your sister, your mother, your girlfriend, someone they care about, and really get them to think about that in a different manner. So would you say that to someone that you cared about or know a little bit more? And then you want to promote other women to leadership roles. So let's say you get invited to be a speaker. You might say, hey, my colleague, Sarah, is also an expert in, XYZ. You want to think about maybe getting her on board. So promoting other people when you get invited to do something. Or you know that there's an upcoming presidential election, maybe of your society, and you know this phenomenal person who you think would fit really well, will nominate them, get them the chance to actually make a difference and maybe get that role. And this is one of my favorite surgeons. Her name is Dr. Stephanie Drew. She was the first female surgeon to be the president of ACOMS, and she helped put on the Women an Oral Maxillofacial Surgery Symposium a few years ago. And she's someone that I really, as like when we came up for voting and I saw her name on the ballot, I made sure that I voted for her. And she really promotes other women and elevates them so that they can too follow in her footsteps. So I love Dr. Stephanie Drew. She's just a phenomenal asset. Extend other invitations to other women, like I said, when you're inviting to something elite. So, hey, Sarah should speak here too. She's great. And hopefully they'll bring them on board. Join women advocacy groups. I'm part of AMWA, which is the American Medical Women's Association. I'm part of the Women in OMFS surgery group. So all of those ways that you can bound together and help get your message out there. And these are examples of all the different ones. There's American Association of Women Dentists, Oral and Maxillofacial Surgeons, the Association of Women Surgeons, and then AMWA, which is the American Medical Women's Association, and they're all fantastic. So how do I advocate for minorities in OMFS? Because that's another big thing. So there are not very many minorities in oral surgery either. So what I try to do is actively participate in organized dentistry and medicine and encourage my minority friends to do the same. On social media, I use my voice. I talk about it a lot. It's not something that I hide in the shadow. I'm proud that I'm Muslim, I'm Arab, I'm Egyptian. I'm a brown-skinned girl and that really helps amplify my voice. I started an IG live series that's called Minority Voices in Medicine, and you can find that saved on my Instagram live page. And I really love that because it gives me a chance to interview really cool people from all different backgrounds and have them talk about why they chose their field. And then I participate in advocacy events in medicine to remind them that dentistry is important too, because a lot of people forget about the dental side. So I did Med Bikini and Share the Medical Mic, and these were two really big movements to encourage or to amplify women's voices. And then also I try to mentor students interested in surgery or OMFS to help them get to their end goals. So these are some of the examples of things that I've done. So Share the Medical Mic was a huge event last summer where we paired up Black women with sort of white women or brown women and gave them a platform to really talk about their field. This was Med Bikini. I don't put pictures on bikinis, but there was also comments about provocative Halloween costumes for those of you who remember that comment. So that was my participation. This is my Instagram page. So when you scroll through, you can see that I talk about advocacy. I look like a surgeon, talk about events that I had of people telling me I couldn't make it. This was Med Bikini. And you can see there's just a lot of diversity on my page. This was Share the Medical Mic with Dr. Jennifer, and we talked about racial diversity in OMFS. So it was a really amazing event. And then I try to do those Instagram Live events. Like this is one I did with oral and maxillofacial surgery Q&A with Dr. Natasha Berridge, who's a Black female surgeon who's out in the UK, and we talked about her experience. So that's kind of the way that I contribute to that. These are also some of those medical mic events. This was one of my best friends, Dr. Earl Campbell from medical school, who is now one of the few GI Black fellows in the country. So I try to amplify a lot of voices where I can. And then this is my final one. From the 8% female surgeons, you can have a life and being an amazing surgeon. So this is Dr. Chi Viet. She's a head and neck and oncology microvascular resurgeon. Dr. Natasha Berridge, who is a UK surgeon who has 2 kids, so she's able to do it all. This is Dr. Jackie. She is an oral maxillofacial surgeon out in Ohio. This is Lindsay Graves. She's one of our oral surgery residents down at Parkland, and she's super involved in organized dentistry. Dr. Mona Stone is a private practice practitioner down in Dallas, Texas. This is Jana Maxillo. She's from Venezuela, and she works in both private practice and academics. Rosalie is one of the rising residents. She's now a senior resident at University of Florida in Jacksonville. Dr. Justine Moe is a head and neck oncology microvascular reconstruction. She has a child, she's married, and she's program director. Dr. Serena is a academic surgeon in the Netherlands. Dr. Rola Rabat, 15 Blades, is up in Boston. She's a phenomenal asset to our field, talks about work-life balance. And then finally me, and I'm one of the few pediatric cleft and craniofacial surgeons in my field, and I also love fitness. And yes, that is me on the front with blue eyes. It was funny, they hybrid me for this picture. So lastly, I'll end with dream big. Anything is possible with hard work, perseverance, and determination. And I love showing this photo. So this was me in private practice. Obviously, I'm super tired. I came off of trauma call. And this was my assistant, Dr. Francis, almost Dr. Francis Morgan. So Francis is a now D3, so a dental student, is third year at Howard University, and he is about to graduate soon. But he went from being my dental assistant to now, on his way to being a dentist. So it's really amazing to connect with people, and now he's been one of my mentors for years. So please reach out if you guys have any other further questions. I am on Instagram, I am on TikTok, I am on LinkedIn. So these are my 2 email accounts for my Penn Medicine, so rania.habib@pennmedicine.edu. My Penn Dental email is habibra@upenn.edu. My Instagram is raniahabib.md.dds, and that is also now my TikTok because I finally joined TikTok. And then my LinkedIn is just my name, Rania Habib. So when you see me flouting my Cowboys, you now know I am a true fan, even though my second favorite team are the Vikings because I grew up in Minnesota. So thank you guys so much. That's all I've got for you today. I know it was a whirlwind. I try to get through everything as fast as I can, and I think I'm just on time. So we'll open the floor to more questions.
Yep.
Okay, let's see what else we have. Okay, see what else we have. I don't know how far back we went. Okay, I think we did these already. So how often do cases require therapy after surgery? That really depends on what surgery we're performing. So a lot of our cleft kids, we do send them to speech therapy or physical therapy, depending on what they're having surgery for, to really make sure that we're harmoniously treating the whole child. I see that you have your dental and medical degree. Does that mean you went to both medical and dental school? Yes, I went to both. So dental school was full 4 years, and then medical school was a fast track medical school that was built within my residency program. My favorite procedure, oh, that's tough. I think the 3 that I showed you, so cleft lip, cleft palate, distraction osteogenesis, and craniosynostoses from the cleft and craniofacial side. From adult side, I love facial trauma. I love putting someone's face back together again. If you could change anything about your pathway, what would it be? That's a tough question. So I don't know if I would change anything. I love the fact that I went to dental school and medical school, maybe just eliminate the 2 years in private practice, but even though it took a little longer to get to my end goal, which was fellowship and then work as a cleft and craniofacial surgeon, those 2 years gave me time to breathe and relax and really pay back my loans and, spend time with family and friends and travel. So I think it was a great break. So maybe that's the only thing, because I would have shaved off 2 years of my life to do what I'm really passionate about, which is cleft and craniofacial surgery, but I wouldn't change it for the most part. I think it was a great experience. How has COVID-19 affected your practice? It has tanked my practice. So I started at Penn in the middle of the pandemic, right at the beginning. So I started last March, so I'm almost celebrating a year. But when you start in the middle of the pandemic and everything is shut down, it affects everything. So it took me until June to get my medical license, my dental license. Then it took me until October to get credentialed with the different hospitals and the insurances because nobody was working. So I didn't even open my own faculty clinic until November. So now I have to try to figure out how to ramp up my practice, but we aren't holding things that we normally hold to bring people in. So open houses or being able to give live lectures. So it's really difficult to get my name out there so that people even know that I'm now at Penn. So it's a really tough, but I will say it's gotten me closer to my students. I have more time to mentor. I have more time to teach in the actual dental school clinics, my resident clinics. So I love that aspect of it, but hopefully I'll be rubbing back up and getting back to my favorite place, which is the operating room. The first question, do you work with physicians of other specialties? Yep, and we talked about that. So I listed all the ones that we worked on. And do I do non-surgical procedures? We do. So if we think about some of the facial cosmetic procedures that we do, we do Botox injections for both facial rejuvenation, but also for TMJ pain. It's a great way to help alleviate some of that pain when it's indicated. I still do some lips, like some fillers for lips and some non-invasive cosmetic procedures, but it's rare. It's not like I do that often because even though I love doing it, my passion is pediatric surgery, not cosmetic surgery. What influenced your passion for surgery? And that's hard. I think just from a young kid, I loved being the aspect of being a doctor. So I'd always grab the first aid kit and help any of my friends or my family who was hurt. And I loved dissecting things. I was the kid who was like, oh, we're dissecting a frog today. Let's look at every little thing. So I realized I liked working with my hands. I'm really creative. And so surgery blended all those things that I love doing. I love, being able to heal someone directly with my hands and have that skill set to do it. And I love just the intricate details of the body. Was it scary at first to do cleft surgery on a baby? What precautions are in place during such surgeries? So obviously, yes. So I think anyone, it's really scary, but when you've got this tiny little baby and you know that every move even means more. So you want to preserve every drop of blood because we know their blood isn't the same, they don't have the same volume as adults. So you have to just kind of minimize everything. So it's making sure, using the right amount of anesthetic based on their weight. And then it's the cleft surgery, there's no baby that's the same, right? So every cleft is different. It could be different with the way the tissue is adhered, the way the kid's gonna heal. So that really keeps you on your toes. And I think that's part of the scary part is, with bone surgery and other things, it's very predictable. But with cleft surgery, when you're dealing with soft tissue, it can be unpredictable. So that's, for me, what makes it very scary and nerve-wracking the first time, but now I really love it. And then precautions that take place, we're always doing those procedures in a pediatric hospital where there's pediatric anesthesiologists and pediatric nurses that are going to take care of the child in the operating room before and after the operating room. And then we're often keeping the baby longer than we would an adult. So they're at least staying overnight, if not a couple of days, depending on the surgery that we're performing, so that we're optimizing their care and we're making sure that they can breathe okay and they're not losing any blood, et cetera. So we're really keeping close watch on them. What is the most interesting aspect of my profession? I guess kind of all of the things that I've already gone over. It's a really wide array and it blends medicine and dentistry. So it's always pretty different, which is really cool. Have you ever had a case of cleft palate that was harder to do surgery than normal? Yes, absolutely. So when you have a really wide cleft, and you don't have a ton of tissue, sometimes you have to stage it and you're not able to perform the surgery all at the same time. So you might close like the soft palate first and give the child a time to grow and then do the hard palate. There are consequences to that in terms of growth restrictions. So that makes it difficult, but yeah, that's why cleft surgery keeps you on your toes, is each surgery can be much different than the last one. What was the most unique case I had when it came to jaw surgery? I think in residency, when I had to do a total joint replacement on the TMJ on both sides combined with orthodontic jaw surgery, it's such an amazing procedure because you're really seeing the transformation on the table. So this gentleman not only had a bite that we needed to fix, but his TMJ joints weren't fully formed. And so we needed to give him new joints so he could open and close well. And so that's a unique surgery because it's it's a ton of planning the joints and exactly where they go in combination with the movements that you're going to move the jaw. So it was very intricate, but it was a really cool outcome. How much of your job is done to help the patient for just cosmetic reasons, and how much of your job is for more urgent health reasons. So with my kids, a lot of the time it's not cosmetic unless we're doing cosmetic revisions. We're doing it mostly for function, but we are always taking into account the form, right? So we want to minimize their scarring so they can look we can reestablish like the lips in the same manner so that we're really building their self-confidence. But function is always my primary aspect. I want them to speak, I want them to talk, I want them to feed, I want them to grow with minimal scarring. So a lot of it's function first, but obviously with my training, I really focus on the cosmetic outcomes as well. So knowing all my landmarks, all my facial proportions, and making sure everything is harmonious. And then the urgent reasons would be, you know, anyone who's coming in with a life-threatening infection of the head and neck. We take care of a lot of those. In the trauma, there might be some trauma cases that have to emergently go to the OR. Some of them might be a very extensive bleed that needs to be fixed right away so that the person doesn't, you know, bleed out. It can be certain eye injuries that have to go to the operating room right away so they don't lose their vision. So those are the cases that become very emergent. And we might combine those with neurosurgery. If there's a massive brain injury, we might need to fix something in the skull so that we can normalize their pressure with neurosurgery. So those are the cool cases that we do, and those are the more urgent ones. What are some experiences you've encountered when working with other specialists? Does it change the way I practice OMFS when seeing different perspectives? Absolutely. So, you know, I've done cool cases with oculoplastics, as you gave an example, where we're reconstructing the eyelid and maybe they're doing the soft tissue and we're doing the bone, or we're working hand in hand to do that. And everyone's trained a little bit different. So I love borrowing those tools that I've learned from them and putting them into my toolbox. You know, in residency, I rotated with ENT, oculoplastics, trauma surgery, neurosurgery, anesthesia, plastic surgery, and I use everything that I learned from them to combine that into my skill set. So it definitely makes me a better surgeon. Okay, when you were doing your joint MD, mine's DDS program, did you feel that it made you a better surgeon? Yeah, absolutely. So the face really relies on how your teeth come together and the health of your oral dentition and your TMJ joints and your facial proportions. And we learn all of that detail in dental school, like to a T. And so that really helps me focus on those intricate details, like are the teeth fitting perfectly? I can speak the lingo of dentistry with my colleagues, and it definitely makes me a better facial and head and neck reconstructive surgery because I'm not just focused on the facial structure, but I'm focused on how the jaws fit together, how the teeth fit together, and the overall oral health. So it's a very comprehensive treatment plan for the patient that includes all those aspects. Why do you normally treat cleft treatments during the first 12 months after birth? So that's because we want to minimize scarring, but also optimize their function. So the lip is done usually around 6 months of age, and they have to meet a certain criteria for landmarks. And that's because we want them to continue to feed. So one of the problems with cleft lip and palate is that their lips, when it's clefted, can't form a good seal around, you know, a nipple or something to get their nutrients, or around a spoon once they're older. So fixing that sphincter, that defect in the lip, helps them now create that suction that they need to, and that form around the to get their nutrients. So that's why we fix the lip in that first 6 months. And then we wait to do the palate until around 12 months of age, primarily because we don't want to create additional scarring. We found that when the palate was fixed earlier in life, they actually had more palatal growth or upper jaw growth restriction, meaning that their upper jaw didn't grow in the same dimension because of that scar tissue. So we do it around 12 months of age because that's when they're starting to learn to speak, and we want them to speak with as much good phonation as possible by reconstructing those palatal muscles. And then we talked about the precautions on babies. What do you think is the most negative aspect or the biggest take back of this profession? So I love my field, but obviously there's a lot of overlap with other specialties. So we overlap with, in the medical world with ENT and plastic surgery. In the dental world, for some of the oral surgery procedures that we do, we might overlap with pediatric dentistry or periodontics, which is the dentists who do a lot of the gum surgery. So there's a lot of overlap. So you often feel that we can do it all, but people are kind of pointing fingers and like, that's our job, that's our job. And so I think a lot of the politics can get exhausting, but I do love what I do. And then I think just the long pathway to our profession. So doing the full dental school, then your 6 or 4 year residency, and then your fellowship, and then 2-year board certification, it can get very tiring. So it's not for the faint of heart. And I always recommend people who are interested in the field to do your research and make sure that you really love it before you commit to it. What age groups do I perform surgery on? Everyone from babies all the way up to adults. I see everyone. My passion are kids, but I see adults too. What are the recent innovations that made cleft lip and palate surgery minimally invasive? Not really a ton, to be honest. There's not a lot of like robotics or things like that we can do. People are trying to do in utero surgery, but that's pretty tough because you can't really like outline the lip and get all of your landmarks and things lined up. So we're still kind of waiting to see if any in utero surgery would actually make a difference in the child once they're born. What made me choose cleft surgery compared to all other subspecialties in pediatric surgery? Specifically because I'm an oral maxillofacial surgeon at heart. So I didn't want to operate on the abdomen or do urology. And so I didn't want to have to leave my field of oral and maxillofacial surgery to pursue other pediatric subspecialties. So in order to do like pediatric surgery, or let's say full scope pediatric plastic surgery where you're doing burn and hand and things like that, I would have to go back and do a medical residency in that field and then fellowship in that field. So this was the best blend of working on pediatric patients, but sticking to oral and maxillofacial surgery. Are there any interesting cases that were hard to treat or almost impossible to treat? Yeah, we see them all the time. So when you think about like, let's say someone neglected a tumor of their jaw or their face, and it's really like eroding into different structures like the eye or the vessels of the neck, those cases can be near impossible to operate on. So we work hand in hand with our medical subspecialists. If they're, let's say it's an oncology patient, is it even resectable? And those are the tough parts. I think one of the other hard things in oral surgery is, you know, those really complex facial trauma where you've lost a ton of soft tissue and bone, and figuring out the best way to borrow different reconstruction. And they might need multiple surgeries and you might not ever get them to look the same because of the scarring. And I think that's really tough as a surgeon because we want them to function and look as good as possible. And so it's hard to do that when you were missing that much facial tissue. So I think that complex trauma where it's avulsive, meaning there's actually missing tissue, are some of the hardest that we do. And the saddest cases, I think, are the head and neck oncology cases of any age, because no matter what you do, you can't control the disease process, right? It's kind of outside of our realm. No matter how much resection you do and it's perfect, you can't control if that disease is going to come back, even with the best chemotherapy and radiation. So it's very unpredictable. And so as a surgeon and someone who loves to be type A and in charge, those cases are really tough. We talked about a day on the job already. What are the greatest obstacles that you have with procedures? What factors affect each surgery? You know, the greatest obstacle is that everybody's tissue is different from patient to patient. So it might be strong in one sense or less pliable in one sense. And I think factors that affect surgery are the things we can't control after surgery. So how the patient heals, how they keep the wound clean, et cetera. So those can be a little bit frustrating. What are examples of technology that you use to treat patients? One of my favorite is virtual surgical planning. So we do CT scans of the patient ahead of time for like bony work. We send it to engineers and we work with them to pre-plan the surgery. What I found is it makes the surgery more predictable because essentially we've done it on a model once. We know the outcomes that we're going to have. We can use those tools to show the patient the outcome, make sure they're happy with where the goal that we're going, because my idea of a perfect surgery might not line up with my patient. So I want to make sure, and that's a really good visual tool. So I love using that as one of my favorite technology. And then we can do like intraoperative navigation. So let's say there's a really complex like eye reconstruction that I'm going to do. There's these special wands that we can do so we know exactly where we are in 3D space while looking at a screen to make sure that we don't injure the optic nerve and we don't enter the different sinuses and things. So it's very cool technology that we can use in the operating room. Why is it better to do what you did rather than go to medical school? So there is no better, it's just your interest. So when you think about like, let's look at plastic surgery versus OMFS for cleft and craniofacial, you have to think about the scope of what you're going to perform. So for oral surgeons who do cleft and craniofacial, we're really sticking to this part of the body, which I love because it's very unique. It's very, you're just doing everything in that one region. Plastic surgeons have really cool training because they do everything from head to toe. So they might also do breast reconstruction, they might do hand reconstruction, burns, they'll still do trauma, they might do extremity reconstruction. So if you're interested in kind of full body, then that might be a better fit. But what I love about OMFS is that I got to do dental school and medical school. So I get to bring those cool, unique perspectives to the table, which is really cool. How long was the longest surgery that you've done? I would say in residency, I did like a 13 or 14-hour surgery, massive cancer, and we did a reconstruction with the leg bone called the fibula, and we did a microvascular reconstruction, and I was scrubbed in from the moment we got to the OR until the moment we closed. So no eating, drinking, or going to the bathroom for about 13 or 14 hours. It was crazy. And then I showed you pictures of how we treat cleft lip and palate. Do you recommend doing biomedical engineering as a pre-med? You know, as a pre-med or pre-dental, what I love is you can do whatever your heart desires as long as you do your pre-medical requirements or your pre-dental requirements. So I would say in undergrad, do whatever makes you happy. If you love biomedical engineering, it might give you a leg up as to latest technologies. You might be able to help develop those technologies once you're in medical or dental school, but whatever makes you happy. I did microbiology and I love it because I really understand viruses and bacterial infections, and it really gave me a good background into what I do. What is the scarring like in cleft and palate surgery? So the scarring is just, you know, scarring of the lip and the palate can actually restrict the upper jaw, so that might bind them to having skeletal surgery in the future. But for the most part, we try to minimize scarring by doing a lot of techniques at home, keeping the wound clear, doing certain massage techniques, speech therapy, physical therapy when needed. So all of those things combined, we try to minimize scarring and minimize future surgeries with the child. When you were doing my joint MD DDS program, did you make you a better surgeon? Yep, and we answered that too. That was, yeah, because I got to do the whole realm of medicine and dentistry. So I really understand the full scope of not only medicine, but oral health and how they all intertwine and how the whole facial structure works together. So I love that part of it. And what inspires me, last question, what inspires me to be a cleft and craniofacial surgeon is just changing the life of a child and then being part of their life for such a long time. So, you know, if that child and their family stick with you on the cleft team, you might be operating on them from the day that they were, you might have seen them from the day that they were born and operated them as young as 6 months, all the way up to any revision surgeries or dental implants that they needed as adults. So I love that patient rapport. I love working with the family and the multidisciplinary team and not feeling like I'm working in a bubble. I think that more heads working together are better than one. I know that sounds so cliche, but it's very, very helpful. And so that's why I love it. All right, that was a marathon. I think we did it all.
Yep. All right. Thank you so much for everything. The pictures and the different types of surgeries that you showed us were super interesting. I actually really loved all of that. So thank you so much for that. And thanks for answering all of our questions.
Of course. Thank you guys for having me. And like I said, just reach out, follow me on Instagram, TikTok, reach out to me on LinkedIn. If you guys have any questions, I'd love to help.
Mm-hmm. Thank you so much. And then for everyone else that's still watching, the Google Forms is going to close at 8:30 p.m. Eastern Standard Time. So make sure to get that done. But yeah, thank you so